No.
My name's Andrea Adler. I'm part of the Fitness, Health, and Wellness Committee, and we plan people to come and give lectures, so I'm giving it myself today. And we also did the scavenger hunt, and we're doing a healthy eating contest where chefs can volunteer and they can make little bites for people, and then we're going to have judges do it, and whoever wins, they're going to get their little whatever they prepare served in the
Restaurant.
restaurant. Thank you. And we had the men's health fair last year, and we're going to have a women's health fair this year in the spring when everything opens up again. I'm a radiation oncologist. I'm not a medical oncologist. I give radiation. And I got into radiation when I got interested in it after I was a first year medical student. At 23, I got diagnosed with my first cancer, which was melanoma of the eye. It was choroidal melanoma. And I actually went to medical school thinking I was going to be an ophthalmologist, but I lost my eye. Can everyone hear me?
Yeah.
That's supposed to be going.
Okay. I lost my eye 8 weeks before my wedding, and so I can't operate, so I chose a different specialty. But my husband's an ophthalmologist, Dr. Adler. So, but I went on, got married, finished my first year of medical school, and went on and became a radiation oncologist, and lived and had 3 sons. And later on, I got breast cancer, so I not only lost my eye to cancer, but I also lost my 2 breasts. So, but I survived that. I'm now 17 or 16 years after breast cancer. But as I finished my chemotherapy, I started not being able to walk up my steps, and they told me that was from the Taxol. But I said, no, I've had patients that had that chemotherapy. This is a little bit worse, and I know I'm not a complainer. And it turned out I had another tumor 2 years later, and that was a ependymoma, which was a benign tumor, but it was still on my spinal cord, so it still caused a lot of problems. So I had to get that out, which was T11, T12, which is right around here. And so I got that out, and then later on, I had, 2 years ago, I had a brain tumor, which was a meningioma, and that actually developed 40 years post the radiation from that I had pre-op for the melanoma. Now, don't get scared, people that had radiation, because this developed 40 years later, which is common 40 years later. I was young when I had the radiation, and I was given very high dose per fraction. I was given on cobalt machine, which they don't use anymore. So it's totally, it was a different kind of radiation, a different dose, and it's not the 5,000 centigrade. There were still a lot of cells alive there, so different kind of radiation in your, if you get it, which hopefully you're not. But anyway, so that's how I got involved in radiation oncology. So today we're going to discuss different things. It's called Cancer Cliff Notes because you can't obviously tell you all about everything that involves cancer. So what will we be covering? I'm going to tell you what is cancer. Then there's a little bit of dry part of the risk factors of and screening for cancer, and the 5 cancers that are screened regularly are prostate, breast, lung, which they didn't used to be able to screen for, but they can now because there's a low-dose CAT scan, colorectal, and cervical cancers, which most of us are beyond screening for, but it's really important for the next generation, so we should hear about that. And then being diagnosed with cancer, what do you go through? What's the staging? What's grading? And the markers. The markers are a really exciting part of treatment for cancers now because they could custom make your treatment. There's so much with immunotherapy, vaccines. There's just a lot going on with the treatment of cancers now. What is staging? What is grading? What are the markers and how are they used? So we're going to go for an overview of the different treatments and surviving cancer. So what is cancer? Because everyone says cancer, but there's 100 different diseases that are called cancer. So why are they all tied up into one thing? Well, in normal cells, they're always dividing. They're nicely organized. They divide in a certain manner. You see they're in nice little lines. That's healthy tissue. Cells can die and they'll regroup, but they do it in an orderly manner. There's all different like checks and balances. But in abnormal cells, something gets messed up in the DNA. They get confused as they're dividing. and something triggers it. So they start duplicating and duplicating and duplicating, and they get all messed up, and then they could break off from the regular grouping, and they could metastasize somewhere else. And that's what makes them a cancer, when it's just uncontrolled. So a disease is cancer when it's caused by an uncontrolled division of abnormal cells. And that's what ties all the 100 different cancers together to call a cancer. So you'll hear the word tumor. So a tumor is defined as any abnormal mass. Not all tumors are cancer. I had 2 tumors that were benign. It doesn't mean they're not going to do anything to you. Some of them are just moles. They're not going to do anything to you. But some of them you have to take care of. So, but they're not all tumors are cancers. Some tumors are cancers. So benign tumors do not invade surrounding tissues, do not invade other parts of the body. They grow slowly and have distinct borders. Cancerous tumors can grow quickly and have irregular borders. They can invade surrounding tissues. They can spread to other parts of the body and metastasize. That doesn't mean all cancers are going to metastasize. That doesn't mean they're all going to grow quickly, but they can. Okay, so that's just the difference between benign and cancerous. Okay, now you might have seen this before because a lot of dermatology offices have it, and it's been a lot of lectures and stuff. It's kind of classic picture. But these are benign moles. They're symmetrical, the borders are even, they're one color, they're smaller than 1/4 inch, and those are ordinary moles. But malignant moles, they're asymmetrical, the borders are uneven, they're 2 or more colors, they're larger than 1/4 inch, and they're changing in size. So you want to always look at your moles on your body. You want to have somebody look at the back, behind the ears, especially men wear a lot of baseball, I wear a lot of baseball caps, but we're all out there golfing. I'm pretending to golf, but you should check behind the ears and the neck. And these are tumors on a scan, well, not scan, but anyway, brain actually. But anyway, the malignant tumor is, you hear the word fingering out. Am I in front of the slides?
No,
I'm sorry.
okay.
Am I talking too fast? I'm from
No,
Philly.
no,
I
good.
talk fast. Anyway, so the fingering out, that's malignant. When they say it's well circumscribed, that's what they mean. There's a nice little border around that, that's benign. So sometimes you'll get a scan back and they'll be doing a follow-up and they'll say there's a well circumscribed little cyst somewhere or it's something, and they go, that's, it doesn't look like anything, and you might be going for a follow-up of a cancer you had, and that will make you nervous because you think you had something, but it's not. It's a well circumscribed nothing, because we all have those well circumscribed nothings all over our body. So, except me, I always have a well circumscribed something, but it's just me. I keep on trucking, but that's a benign tumor. Okay, so obviously there's other risk factors, but these are risk factors that we can change. Okay, because we can't change our genes, we're stuck with them. But we can sometimes do something about our genes, like the BRCA1 gene or the BRCA1 or BRCA2. If you know that you have that gene, there's something you can do. Like some women decide that I'm going to get a bilateral mastectomy ahead of time, or I'm going to go on a hormone drug ahead of time to prevent the breast cancer from developing. You could go on some studies ahead of time if you know that you have the BRCA1 or BRCA2, or I'm just going to be followed very carefully. I'm going to go for MRIs and mammograms from a very early age. But talk to somebody, talk to a physician if you have the BRCA1, BRCA2, and make a plan from a very, very early age. If you have a daughter or a granddaughter that has that gene, make sure that they're discussing it with a professional. And it shouldn't be an internist, it should be an oncologist that they talk to. But risk factors and screening from some majors, that's our next topic, but smoking, obesity, sedentary lifestyle, alcohol, a poor diet, unprotected sex, and excessive sun exposure are all things we could change to decrease our chance of cancers. So the first cancer we're going to talk about is prostate cancer. Any man, as they increase in age, is going to be at risk for prostate cancer. Black people have a greater risk and also are more likely to have a cancer of higher grade or higher stage, so they should start screening earlier. a family history of prostate cancer, and a family history of BRCA1 and BRCA2 puts a man at higher risk for prostate cancer. BC is more likely to recur, and also their cancers are going to be worse. BC is more likely to recur, so it's not like more likely to get the prostate cancer, but it's more likely to be a higher grade. And smoking tobacco, there's some controversy on that, but we all know smoking is bad, so clients will stop. 98.9 of those diagnosed survive at least 5 years, and that's what makes the screening so controversy, is because men survive prostate cancer without the treatment too. So it becomes a very controversial subject. But 29,000 men die annually from the disease, so it's not that everyone is surviving it. But okay, so if you look at different sites, they're all going to tell you something different about the screening for prostate cancer. So I got this from the urology site, because they're who's treating most of prostate cancer and doing the screening. And if you're confused about it, your internist is telling you one thing and you're not quite sure, you speak to the urologist about it, because they're doing a lot. They're the ones that, if you decide to get a biopsy, are going to do the biopsy. They might be a little more aggressive, but just make sure you're comfortable with who you're talking to. So discuss your screening with your physician. Don't just go for the PSA without discussing it first. Like, think about it. What do you want to do with the findings? Do you want to get treated? Do you want the biopsy? Don't just go for the blood test blindly. So PSA between 45 and 50 is the baseline, then every 2 years to 50 to 69. PSA 40 to 45 for people of increased risk. And then above 69, discuss with physicians. Digital rectal exams may add to established risk. Now, they say the PSA velocity should not be used as a sole indicator for biopsy or further imaging. PSA indicator means how fast is your PSA increasing. But they do use that in addition to other things. There's also the 4K score. So the 4K score will look at your bound PSA, which is bound to protein, your free PSA, which your PSA test gives you your free PSA. So they're going to look at the ratio. So the combination between the free and the total PSA is calculated, and the free PSA is more common in non-cancerous prostate conditions. So you want the free PSA to be higher. So if you get a poor PSA test, like above 4, and it depends on your age. Like if you're younger and your PSA is above, if you're like 40 and your PSA is like above 2.5, they'll be more concerned than if you're like 69 and your PSA is above 2.5. They'll wait till that's above like 4. And so it depends on your age on what the abnormal PSA is. It takes a lot of discussion with PSA. You really have to go ahead.
What is the average PSA level that?
Well, it should be low. Like it should be like 1,
so the
2,
lower the number,
3.
the
The
better.
lower the number, the
Okay.
better.
Okay.
And it depends on your age too. And plus other things can happen. Like if you have sex right before you have your PSA taken, it's going to make it higher. Or if you have an infection in your prostate, it can make it higher. If you're on cholesterol medicine, it can make it lower. So there's a lot of things that will affect your PSA. So you can't just get a PSA test back and say, oh my God, I need a biopsy.
You're right, your
But-
bicycle, it'll get higher too.
Yeah,
Oh, okay.
yeah, because you're gonna get it. You're gonna get an inflamed prostate. So they'll take your PSA. They'll always want to take another PSA if they get an abnormal PSA back. So you don't rush into that. Plus, now they could do like an MRI of the prostate. They could do this 4K score, and get free PSA level to bound PSA level. There's other things that they can do before they rush into a biopsy. Because lots of times they like when I began working, they would do a biopsy. Oh, they missed it. Do another biopsy. Oh, they missed it. And these guys would wind up like a lot. And it's an uncomfortable biopsy, if you can imagine. So you don't want to just rush into that's why they're getting away from these biopsies, because it's older men that are getting the prostate cancer, and they were saying that survival didn't increase, but morbidity does, because like if you get the bone mets, it hurts. It decreases your mobility, and it can be, there's a lot of treatments that are less invasive for the prostate cancer now. I mean, the iodine seeds are well tolerated. There's high dose rate brachytherapy, which I'm going to get into. I'm getting a little ahead of myself, but there's treatments that are easier to do. There's less there's less invasive surgeries that are easy to do. So I'm telling my husband to get his PSA. That's all I can say. Right.
Having gone through this too, another thing is the PSA density, the PSA divided by the size of the prostate.
Yes, that's part of
So-
the 4K, yeah.
Yeah.
They look into all factors evolving before they rush into the biopsy now. So it takes a long discussion is what I'm trying to say. You have to be involved, you can't just rush. Whoops. Okay, I'm sorry, I pushed back too much. Okay, so then breast cancer. So breast cancer risk factors. Okay, so everyone wants to talk about the genes, but the most important thing is being a woman, because most people that are diagnosed with breast cancer don't have the gene for the breast cancer. They don't have anybody in their family that has breast cancer. They're just a woman over 50. Of course, I wasn't over 50, I was 48, but I like to do things backwards. But being a woman is a risk factor for getting breast cancer. The age over 50. Starting menstruation before 12 or menopause after 55, there's nothing we could do about that. Dense breasts and atypical ductal hyperplasia is a risk factor. And that's important because dense breasts aren't always really great for mammograms. So a lot of insurances will cover MRIs for dense breasts, or at least make sure you're getting a 3D mammogram, which most places have. It's interchangeable with diagnostic mammograms, but make sure your diagnostic mammogram is also, it's actually a 3D mammogram. The first pregnancy after 30 or no pregnancy is also a risk factor, but you can't change your plan. If you had radiation to the chest before they were 30 years old, but that's not getting radiation to the chest when you're 60. You're not going to get cancer when you're, like if you had it for lung cancer. It doesn't develop breast cancer at 70 from that. It takes a very long time for the radiation therapy to develop breast cancer from that. It took mine 40 years. Oral, but I'm alive. Oral contraceptives with estrogen and progesterone for many years, and that's like the old high dose estrogen and progesterone. You had to take it for a long period of time. They've adjusted the doses that they're giving people now. Drinking alcohol, not your one glass of wine every once in a while. They're drinking regular alcohol. Being overweight or obese after menopause, that's going to give you a risk for a lot of different things. Being physically inactive, okay, and the family history of breast cancer or ovarian cancer. And if you have breast cancer, you're at risk for ovarian cancer. You're also at risk for colorectal cancer, so you want to follow up on that. And genetic mutations of BRCA1 and BRCA2, and I've already spoken about that. Okay, so breast cancer screening. And again, if you look on different sites, you're going to get different answers. And this changes all the time. And you have to look at who's on the board. Like one of the prostate cancer screening boards, they had a pediatrician on it. Yeah, so I just found that out a couple weeks ago. Yeah, so they change this all the time, and a lot of the reasons is because it financially wasn't feasible for them to continue the screening the way they wanted. So you have to talk to your physician, take an active role, know what you're comfortable with and what your insurance covers and everything. But between 40 and 45, an option yearly mammogram. Between 45 and 54 should get yearly mammograms. And this is for average risk people. Okay, and I love the wording on this. Between 55 and older, switch to every other year or choose yearly mammograms. I would choose yearly mammograms. Okay, and then, listen ladies, screening should continue as long as a woman is in good health and is expected to live at least 10 more years. Okay, I don't know how they know what we're expected to live. They would have stopped mine a long time ago and I'm here. So, I didn't write that. I mean, I put it on there because that's what they said. But I would continue, because your risk is higher. What do you think, Jason? I don't like that wording. I mean, if you really have a lot and you're really a lot of other really bad diseases and everything, I could understand not going. But we're all doing great at River Strand. We have a healthy looking group here.
There's a really hard balance between trying to do things to identify a cancer, and the expense of identifying it, and also the expense and the morbidity of a false diagnosis. And if
Yeah.
something has a low prevalence, if only 10 in 100,000 have the disease, but the test is 1% wrong, that means 1,000 in 100,000.
This 1 in 8 get breast cancer. 1 in 8 women get breast cancer. So we're not talking about a rare disease here, but there are a lot of false positives. And they're getting much better. So,
On the other hand, there's false negatives.
Yes.
I had a mammogram and an ultrasound and a biopsy, and they said it was benign. I said, well, let's take it out because it was, I had breast cancer before. And then when they did the lumpectomy, the pathology report came back, oh, wow, this is cancer. But it was supposed to be benign. And so they had to go back and clean the margins and whatever. So,
yeah.
you know,
And
be careful.
no test is perfect. I
Yeah,
mean, my
be careful
mammogram
and
was, they kept
follow
on, I got my mammogram and they said, oh, you just have dense breast, that's nothing. I said, but I think it's something. And they said, no, it's nothing, you're just hyper because you had cancer before and you're in the field and you treat breast cancer all the time. So I said, well, I'm gonna get another mammogram in 6 months. And they said, you're crazy, but I know I am, so that's okay.
Mhm.
So, and then I felt a lump, which they say doesn't help, but sometimes it does. And I felt a lump in a couple months from then, and I said, I'm getting another mammogram, because, you know, they didn't do MRIs at that time, or they were just starting to. And then they saw it, and I said, see, that looks worse now. And then I was diagnosed with the breast cancer right where I told them it was in the first place. But whatever. You can't point fingers, at least they saw it. But at any rate, the self and physician's exams, they did not improve survival in any of the studies. But know your breasts. I knew mine, and that's what happened. But the high risk patients have different recommendations. The breast MRI and mammogram from age 30, so you should start much younger. Or, as I said before, there's other things that you could do to protect yourself from the breast cancer. Opt for bilateral mastectomy, go on a hormonal therapy, tamoxifen, or some one of the other treatments. So what is high risk, the BRCA1, BRCA2, or the previous chest radiation before 30? MRI has no official recommendations have been made for women with dense breasts to use MRI or 3D mammograms, but both have improved imaging. And insurances will cover the 3D mammograms. They sometimes will cover the MRI. It depends on what insurance you have and what your doctor's saying, what wording they're putting in there. Okay, so we're on to lung cancer. So there used to be like no...
Does ApoE status affect your, put your risk for breast cancer?
I'm not really
ApoE4,
sure.
okay.
Not really sure. Sorry. Lung cancer, so the major risk for lung cancer is smoking. So even smoking occasionally for a few cigarettes a day increases your chance of lung cancer. Secondhand smoking causes 20 to 30% increased risk of lung cancer in people who do not smoke. So secondhand smoke causes more than 7,300 lung cancer deaths each year among non-smokers. So my girlfriend died of secondhand smoke. She never smoked a day in her life. Her father smoked, and she died when she had 2 kids at home from secondhand smoke. So I really push this. A 2008 study in NIH also showed an increased risk of lung cancer from long-term marijuana use. So remember that. There's other studies that contradict that, but we're going with this to tell all our sons, granddaughters, grandsons, quote that study. And forget it for any of us that still smoke. No, I'm just kidding. Air pollution, radiation exposure, arsenic in drinking water, family history, asbestos, and radon. But, okay, so now there is lung cancer screening. So low dose CAT scans every year for people at high risk. Okay, so what are people at high risk? They have 20 or more pack a year of smoking and smoke now, or have quit within the past 15 years and are between 50 and 80. So all those things together, then you need a low-dose CAT scan every year. So a pack a year is 1 pack a day for a year. So you can reverse the damage from smoking. If you quit, your lungs will start repairing themselves. It takes a long time, but they can start repairing themselves. So if you have somebody young that you know that's smoking, if you get them to quit, they can repair themselves. That's why it says, have quit within the past 15 years, because if they quit 15 years ahead of time, it will start repairing. So I have a son that smokes cigars, and I'm really, he just got the nicotine patch. So I'm very proud that he got the nicotine patch. And he has no kids yet. So discuss risks and benefits, including your health with a physician. So they tried a lot of studies where they did chest x-rays and sputum cytology, but that didn't decrease the risk of dying from lung cancer, because by the time it showed up on there, it was just too late. So this is the low-dose CAT scan just gives you the dose of a chest x-ray. And so it's not good to use. So you're going to think, like, why don't they use the low-dose CAT scan on everything? But it doesn't show the bones really well. This picture isn't that good because it's showing some of the bones, but really it doesn't show the bones and everything else. But the lungs are air, so it can show the mass really well.
I don't see that. I'm not sure I'm looking.
This is the mass. That's the lungs. That's the heart.
Oh, okay.
Did that answer your question?
Yeah.
And look how much more in focus the one on the right is the standard dose. See how the lump?
This is a regular CAT scan.
Yeah.
You can see
But
it.
usually,
see
I mean,
more
these are
detail.
bones, and you could see bones, you could see the heart, you could see the different things in the heart much better. You can't really see that on this one. So you're not really going to see the rest of everything you're looking for on a low-dose CAT scan. But you could see the lungs really well because they're air.
Right.
So I'm used to looking at it.
So you're saying that had an X-ray?
That you can't, for screening, you can't do a chest x-ray.
Okay.
I mean, as far as a large group of people,
Mhm.
because by the time they find it, like maybe on one person,
Mm-hmm.
on an individual, they might find it soon enough. But if, in a large study, they didn't find it on enough people by chest x-ray for it to make a difference. Because a CAT scan is going to take small slices.
Okay.
A chest x-ray just does, one shot from the front, one shot from the side,
Mhm.
and everything's superimposed on each other, and you're going to see bigger masses. You're going to see smaller masses on CAT scan.
Okay.
So you're more chance to cure it.
Okay.
You're not talking about trying to cure it.
Okay. So it's more visible of a CAT scan more so than what?
Right, but you want to get low-dose CAT scans, because on
Right.
a low-dose CAT scan, it's covered. It's covered by insurance now for screening for those particular people.
Okay.
If you can't get it covered, get the chest x-ray, because you could talk to your doctor into getting it for you, and
Okay.
you might find it. Did that answer your question?
Yes, it did. Thank you.
Okay, so colorectal cancer. Okay, so again, if you look different places, you're going to get different recommendations. So this came from the gastroenterologist group for the risk and also for the screening. So age, although younger people are being diagnosed now, and that's because they're eating more processed foods and fat and stuff. Family history of colorectal cancer or polyps, hereditary cancer syndrome, Lynch, and FAP, which is a polyp disease, which they have like a lot of polyps. They usually lose their whole colon at one
What
point.
is Lynch?
I actually forget. Do you remember what Lynch is?
Is that the syndrome with the skin?
I know
With the skin
FAP
lesions
is
too?
a familial adiposis polyposis.
Yeah.
Sorry, I meant to look it up. You
Okay.
caught me.
Cancer syndrome, Lynch, I never heard of that.
But obesity, a diet high in red meat, processed food, and low in plants, inflammatory bowel disease, which a lot of people have, but you're at a higher risk, so you're usually getting followed by colonoscopies and that anyway. Black race and Ashkenazi Jews and Alaskan natives, so you need to be careful of that. And heavy alcohol use in smokers will put you at a high risk, and this is just the whole thing. God, I looked it up, and it went one way out the other. Okay, so colorectal screening. Okay, so this is from the gastroenterology recommendations. So people at average risk should start screening at 45. So it's 45 now. It didn't used to be 45. Now it's 45. Okay, and FIT also, which is a stool sample kit. So you're going to hear a lot about a lot of different kinds of stool sample kits. This is FIT, and this is only takes a little swab of the stool. Okay, and you're supposed to do that every year. Okay, which a lot of people probably aren't doing. And so you do that every year in between getting the colonoscopy every 10 years. So if your colonoscopy is normal, you get that every 10 years. But you're supposed to be doing the FIT in between, okay? So people with a family history should start earlier than 45. Other stool tests are available for home tests, like Cologuard. Cologuard, you take the whole stool sample, but you do that every 3 years. Now, Cologuard has, they have a very high rate of percent of positive,
False positive?
finding the cancer, higher than FIT. But the thing is, you're doing it every 3 years and not every year. So that's why if you do the math, the FIT is still better because you're doing it every year. I'm not sure in the future if that's going to change because people are more likely to do something they have to do every 3 years. So you have to watch. Time might change that. But, the other way people are opting to get screened sometime is the virtual CAT scan, because you could avoid the colonoscopy. But the problem with that is they can't take a biopsy with the virtual CAT scan. So if you're going through a colonoscopy and your doctor finds a polyp or finds something else that they find that they don't like, they could do the biopsy right then. If they do a virtual CAT scan and they see something they don't like, you're still going to wind up with the colonoscopy. So the colonoscopy is more recommended, but some people just are not willing to go through. And you still have to take a prep for the virtual CAT scan. You still have to be clear. So I would recommend the colonoscopy. It's not fun, but. And then a septin 9 is a blood test. It's not recommended for screening, but some people just refuse to do anything else. I'll show some of this. Okay, so cervical cancer risk factors are, and the reason I have this in here is that, well, I'll get to it, but cervical cancer risk factors are smoking, HPV, increasing number of sex partners, early sexual activity, which leads to a chance of HPV, other sexually transmitted diseases, infections, weak immune system, and I don't think anybody, it's exposure to DES from a parent, which was way back when. Okay, so HPV vaccine is recommended for girls to prevent cervical cancer later in life. They need 1 or 2 doses for younger age, so that's 9 to 14 years. If they're a little older than that, up to like mid-20s, they're going to need 3 doses. And 2 or 3 doses for immunocompromised individuals, such as people living with HIV or AIDS. But
Has that been proven to be effective for the girls?
yes, it is a very effective vaccine and it's worth getting.
Do they have to get it annually?
No, you
Oh.
just get one,
One time.
no. You only need 1 or 2 doses,
Okay.
yeah.
If I may also, oral, the fastest growing cancer in the world, that is year over year getting more and more, is HPV related to oral cancer, tongue, tonsil, throat cancers from HPV.
And it's very painful.
Very other you wind up losing your jaw, you lose your face, and this vaccine is also effective at that too.
And the
He's an ENT
HPV is
doctor.
hepatitis?
HPV is human papillomavirus.
Human papillomavirus.
Oh.
Causes warts. A subset of it causes warts. It's not exactly the wart virus, but it gives warty-like lesions.
Yeah.
Another type of it. It's not, but that's not the one that causes wart. The typical wart is not caused by this one.
Oh, okay.
Oh, good.
Yeah, I mean, I put it in here because we're all kind of too old for this vaccine, but a lot of us have granddaughters and stuff, and I think it's important we want the next generation to be,
This is the one they advertise on television
Yeah.
on a regular
Yeah.
basis.
yeah. Okay, cervical cancer screening, there's a pap test at the 21, then every 3 years if normal, then can vary. So it's 30 to 65, you have to talk to your doctor. The main thing about this talk is you're being an active participant in your care. I mean, a lot of times with cancer, they're not gonna tell you how to get treated. They're gonna say, these are the options, and you're gonna have to decide. And sometimes they're not gonna give you all the options because they don't have all the options in where you're talking to. And you're gonna have to, and you should find out the options. Like the first place I was at was Georgetown University when I was diagnosed, and they didn't have all the options. You would think a university like that would have all the options, but they didn't. And then when I was diagnosed the second time, they didn't have all the options either, and I had to go somewhere else. Like so I was lucky in the fact that I could go, and I realized that I was fortunate. But you have to find out the options. But at any rate, cervical cancer screening between 21 and 29 is pap test at the 21, then every 3 years if normal. This can vary between 30 and 65 options. Talk to your doctor. HPV test only normal, repeat 5 years, and pap test only normal, repeat 3. Or you could, okay, there's 3 options. HPV test only normal, repeat 5 years. You could get the pap test only normal, repeat 3 years, and both if normal, repeat 5 years. The pap test is more effective than the HPV test. So if you're getting examined anyway, you might as well get it. 65 and older, you may no longer need it. Screening if you had 3 normal pap smears or 2 normal HPV tests in the past 10 years. If you have not had cervical precancer in the past 10 years, and if you had your cervix removed, obviously you don't need it because you're not going to get cervical cancer. Okay, now this is a brand new test. Okay, there's a lot of controversy around this, but you might hear about it, so I should put it in. It's kind of exciting, but it's going to be exciting in the coming years. The Gallery blood test tests for more than 50 different cancers. They just draw your blood. It's not FDA approved yet, but people are getting it. It's cancer shed DNA fragments, and they're in your bloodstream. They're called cfDNA, okay? Cell-free DNA. And the Gallery test detects the cfDNA. It tests for over 50 different cancers, but the patient still needs to go through further testing to be diagnosed, okay? It costs more than $1,000 to get. And most of the studies were done by the company. And they stopped it for a little while and then continued it, which makes it like a little bit iffy, because it was getting a little false positives, and you kind of have to wonder a little bit. So if the positive test is called cancer signal origin. So I'm not rushing in, even with my history, I'm not rushing in and getting this yet. I mean, this is up to you. I'm giving you the information. It's up to you, but I'm waiting. That's all I can say.
Would that be available anywhere or just?
I didn't call up and
specific
find out who was giving it.
Oh.
I talked to somebody I happen to know in Charlotte, and he's doing it.
Would NIH have that?
Yeah, I'm sure. You know what? I can't even say that. I didn't call around to find out who's giving it, but I do know that if you call like Florida Cancer Institute, they would know the answer to that. Or if you call Moffitt, they would say we're doing it or we're not doing it, but this is where you could get it. You know. So now you went through all the screening and everything else. So if you're being diagnosed with cancer, so the first thing you want to do, I gave you some websites that have some information about the cancers because I couldn't print out all the millions of pages. Okay, but I guess I could, but I chose not to. But so if you're being diagnosed with cancer, you want to educate yourself about the cancer. I mean, doctors hate that, but you really should anyway. So you want to go to the right websites. The Mayo Clinic has a good one. Cleveland Clinic has a good one. NIH. Go to like the major centers and look. And they explain it in terms that everyone could understand. WebMD is a good place to start. Like if you want to start at WebMD, you start at the American Cancer Society, but then go into these other ones because they'll get like deeper. You need the deeper information. And remember that your case is unique. So people are gonna throw information at you, and you're gonna have to like block them out. They're gonna have different stages in you. They're gonna be treated like years before you were treated. So the treatment's not going to be the same. They're not gonna offer like the same things. There's so many new treatments out there that you might not, they might have been treated like how I was treated isn't how somebody else would be treated now. No one would get how I was treated for the eye isn't how they treat anymore. And I can't look back and say, oh no, I got treated correctly. I got treated by the best hospital there was at the time. And now that hospital would treat differently, but it was 40 years ago. Yeah, so you can't go by that. So you're an individual. Write the things down. Write your questions down before you go in, because they're gonna start talking and you might forget what you wanna ask. So make sure you write it down, what you wanna ask, and check it off, and play an active role in your treatment. If you have a high stage cancer, ask about studies. Like you might wanna look up some studies beforehand, and you wanna ask before you start treatment, because sometimes if you start treatment, then you're not gonna be eligible for the studies, because if you got certain chemotherapies, then they don't let you into the studies. So if you do have certain or unusual cancer, they might not let you into the studies. I always say to take somebody with you to an appointment, but I did talk to somebody the other day and she said, well, I don't like to take anybody with me. So do what you're comfortable with. But usually they say to take somebody with you to an appointment, because it gets blurry and it's good to have two sets of ears with you. American Cancer Society has a lot of support. They have people to drive you to appointments. Radiation Oncology takes several appointments. Sometimes you're getting 25 treatments. They have somebody to drive you back and forth. They have pamphlets. Their pamphlets are usually pretty simplistic, but it does start you on information, and you have to start somewhere. It's okay to ask the doctor to repeat what they said. These are all new terms. You've never heard of them before. I got in trouble in the first place that I worked because they said I was taking too long with the patient. They wanted me to spend 10 minutes explaining radiation and the side effects, and they said, don't say the side effects. Needless to say, I wasn't there that long. I just didn't agree with that. I open up my mouth when I don't agree with something. So I'm a Philly girl, but the other place was wonderful. But anyway, but ask the doctor to repeat what they said and make sure you know what you're getting yourself into. And also keep a separate folder, either printed or on your computer, because they have all these patient portals, but they're all different, okay? So make one portal with everything in that portal. You know, I have a little folder that has everything in it. My MRIs from everywhere and all my blood work and everything that's in that one folder that I know where to go to. And then, you know, I have it right there. So I have most of it printed out too. But especially if you're going back and forth from the north to here. And your records are yours. If you want the CD of any of the MRIs or anything, you could get it. Second opinions are great. If somebody gives you a hard time, that's not the right doctor. And you might want something different than your family. I mean, my whole family wanted me to go for a new radiation treatment, which was just new, and a plaque, and my tumor was way too big for the plaque at the time, and I just wanted it out. You know, my mother-in-law didn't want Jordan Wall to an eye. You know, so sometimes they're pulling you or pushing you in one direction or another, and you know, you need to know what you want, not what you know. And you know, you could explain it to your family, but you need to know what's comfortable for you. And everyone was surprised when I had breast cancer that I wasn't going to go get the radiation, but I knew where my tumor was. I knew the radiation. I knew it wasn't going to be right because of the way I was built. But I knew it was right for me, and it all worked out correctly. So, okay. Remember when you hear the word cancer, it's not a death sentence, especially these days. Even metastatic cancer, they have so many treatments. I know somebody with metastatic melanoma that had it in several different organs and got treated with immunotherapy. Now, it wasn't easy treatment at all, and he's not young and wasn't in great shape, but he's walking around with no cancer for several years. I mean, I'm not talking about he just finished his treatment and is doing well. I mean, this is several years, and he's doing phenomenal, and he's all healed up. So in 2022, 70% of survivors in the United States have lived 5 years since their diagnosis, and 48% of survivors in the United States have lived 10 years since their diagnosis. And the numbers are improving all the time. So just remember that. Okay, so the first thing they're gonna do when you get, it might not be the first thing, but one of the things they have to do when you get diagnosed with cancer is they're gonna have to figure out the stage of the cancer. Okay, so what is stage? You're gonna hear stage, grade, you're gonna hear all these different things. So stage of the cancer is how big is the cancer, okay? So the lower the stages are smaller and less involved. How large is the cancer? Is the cancer contained within the organ, or did it extend outside to nearby tissues? Are lymph nodes involved? Are distant organs involved? So stage 0 is like carcinoma in situ. It's almost like, it's not really, it's like pre-cancer. It didn't really invade yet. So cancer cells are found in the earliest form. It means lucky, lucky, lucky. Okay, but stage 1 is still a small tumor that hasn't spread. Stage 2 is cancer that has grown more deeply into nearby tissues. Stage 3 is cancer that has spread to lymph nodes or nearby tissue. And stage 4, it's gone to other parts of the body. So this is colon cancer. Stage 1, you can see it's just like small, and then stage 2, it went into the wall. Stage 3, it went through the wall. There's a lymph node there, and stage 4 is spread to other parts of the body. Okay, then you hear TNM staging. I'm not going through this whole chart, don't get scared. You want to leave. But T is the tumor size. And I put a website on so you could like read at your leisure. But just to explain it to you, T is tumor size, like is it 0 to 2 centimeters, 2 to 5, 5 to 10 is attached to the wall. N are the local lymph nodes involved and how many. M is did it metastasize yet, and then they get into smaller things like T1A, T1B, you know, because they like to tease us in our boards, but it does tell the prognosis though in all seriousness, and it groups them all together in T and M staging, and it tells you a prognosis. It tells the doctor different ways they need to treat you and how much they have to give you, and what chemotherapies they need to give you. Do you need chemotherapy? Do you not need chemotherapy? Do they need to give you the radiation? Well, it tells them how to treat you in this TNM staging but it's still staging. It's still the same kind of 0, 1, 2, 3, 4 staging. Once they get it, all the TNMs grouped, it's the same theory. So then there's grading. Grading is completely different. Grading looks microscopically. It deals with, under the microscope, just the cells. How different does the cancer cell look from the normal cell? How fast is it duplicating? How angry do those cells look? Okay, so again, the 1 is better and the higher numbers are worse. So well differentiated, like it looks like, grade 1 looks like a normal cell. See, they're like kind of lined up. They're doing what they're supposed to do. Grade 2, they're starting to look a little mixed up. They're duplicating a little faster. Grade 3, they're poorly differentiated. They're not lined up in nice little lines, and they're duplicating faster. And grade 4 is undifferentiated. To use a scientific term, they're all messed up. They're duplicating faster. But that's pretty much the theory of grade. Okay, so you hear Gleason's grade, okay? There's some prostate cancer. I don't know why they make it so complicated. So there's Gleason's grade and there's Gleason's score. And then there's grading group. Yes, because they can't decide. You get 10 doctors in a room, no one's gonna say the same thing. Okay, so Gleason's score, it's more common to start at 3 because you hardly ever see 1 and 2. But it really starts at 1 to 5. It's Gleason's grade. They look at 2 different parts of the cancer, and they give the 2 different parts of the cancer a grade. So that's why it says 3 plus 3. Those are grades. So they looked at 2 different parts, and they saw 3 and 3. Threes are pretty low grades. And then they add those together, and they get a score. Is everyone on the same page? Okay. So the score is just adding 2 of the grades together. So when you hear somebody talking, you have to listen whether they're saying grade or score. because a score of 6 is low, but a grade of 6 is high.
I have a question. When you're taking the samples, is it from the same tumor or same
Yeah,
place?
no,
Not
it's two different
places.
places, but in the same in the same cancer. Yeah, it's
Oh,
from the same guy.
cancer, just two different areas?
Yeah, the
Okay.
guy has a cancer and and they're taking 2 different samples from the same cancer on the same guy.
Okay.
They're looking at the microscope and seeing the most common abnormal area and the second most
Yeah,
type of
he
abnormal
explained
area.
that.
But they also do 12 biopsies too,
Oh, okay.
and so each one is graded.
So this one's like, well, so it goes from 6 to 10, the score. But now they're trying to get away from that and go to grouping 1 to 5 in the score. So, and so then we get into the most exciting part of what's going on in cancer treatment. Now, so markers, there's all different kinds of markers. And it can get a little confusing, but they're present in or produced by some cancers and give information about how aggressive the cancer is and what treatment the cancer may respond to. And they allow for customized treatments. So they can be found in a lot of different things. They can be found in blood, urine, tumors, stool, other tissues were traditionally proteins, but now include genes, mutations, and other DNA changes. Some markers can track how well cancer is responding to treatment. Now, some of the markers that you hear about breast cancer aren't used to follow breast cancer, but some can be. They kind of look that up. But like when you hear like the genes, like BRCA1 and BRCA2, that's not used necessarily to follow the treatment, or HER2, that isn't used to like follow the treatment, but like HER2 or estrogen markers and progesterone markers, they're used to like HER2 and estrogen and progesterone, they're used to like help decide what treatment you should get, but they're not necessarily used to show you how the treatment is doing. So some markers will help tell you what treatment you should get, and some markers will tell you how is the treatment doing. Now, these are some old classic markers that are more general, that are like in the blood, that will tell you like how did your cancer come back, what's going on in the blood. These aren't like the new markers that are more customized towards treatment. Like CA-125, you can see is very general. Like you could get your blood drawn and see like, is it in my blood, and is something going on in my blood? But you can see it shows up in breast cancer, lung cancer, pancreatic cancer, ovarian cancer. These are more general things. These aren't the customized things that are telling you how to treat the cancer. This can be used. Vaccines have been developed using markers on tumors for melanoma, NGS markers used in metastatic breast cancer, and clinical trial eligibility. So, wait, I get into it later on. And these are all ways that they can be used to customize the treatment. Does anybody have a question on?
Were you saying before, I think you were saying before, that there are certain markers, certain chemicals, genes that are part of you, like BRCA gene, that will predict your chance of getting something, and then there are things that are markers of the tumor being there, that you can follow, like HER2.
HER2 is in the actual tumor itself.
Right, those are the ones you follow.
No, well, HER2, it won't necessarily change. Like HER2 is just going to tell you what chemotherapy to use. But there are other markers in tumors that they can use, that there's other DNA that's like cell-free DNA that will change in the blood that they can follow. So there's different kinds of. Did I answer your question?
Yes.
Okay. So then you're going to get into, after you get all that, and they get all your markers down, which is really important, then they're going to tell you what treatment you're going to get. And it's important to be part of deciding your treatment. So one of the treatments can be surgery if you have a local kind of, and one is radiation, which is also mostly local. Although for prostate cancer, there's also they can attach radioactive the radioisotope, and it will guide to bone mets now, which they can give before chemotherapy now. It's just approved to be given before chemotherapy. Chemotherapy is also systemic, which is immunotherapy and vaccines. And they're doing the messenger RNA vaccines now, if they don't stop all the research. Treatment is, as I said, treatment is a team effort. And sometimes the order is controversial. Like sometimes the medical oncologist will want to give the chemotherapy before the surgery, and sometimes the surgeon will want to give the surgery before the chemotherapy. Sometimes the reason for giving the chemotherapy first is to shrink the tumor so the surgeon can do the surgery more easily. But sometimes they don't always agree. So like I knew I was going to get chemotherapy for my breast cancer, so I went to the medical oncologist first and spoke to them, and I was going to need a port, which I kind of knew. But so I was able to get my port put in during my mastectomy so that it wouldn't have a scar, because I'm vain. But sometimes if you do that, you can prevent a second surgery. So if you talk to a team first before you're treated, and you have a team approach to everything, you could avoid sometimes getting a second surgery. And like I had the plastic surgeon in there with the breast surgeon, so I had everything done at once. I didn't need any extenders. So even if you know you're getting a mastectomy, there's several different kinds of mastectomies, and you want to make sure you're talking to somebody that does all the different kinds of mastectomies. The kind I wanted, I wasn't a candidate for, and I was 70 pounds heavier, so believe me, I had a lot of fat, but I wasn't allowed to lay on the table that long because I have another neurologic problem. But you know, so sometimes you can't get what you want, but at least you could talk to all the options. And you want to know how often your surgeon is doing that kind of surgery. Because one of my surgeons, I was at one place and they weren't doing that surgery that often. So I didn't want a surgeon that was doing a surgery like 3 times a year. When I had my appendectomy, I wanted somebody that was doing that surgery all the time, because I wanted to walk again.
Mm-hmm.
Walking again is important. So these are important questions to ask, especially if you have a tumor that maybe isn't that usual, a tumor.
Do you recommend a second opinion or third opinion?
I do recommend a second opinion if you're in many cases. I recommend a second opinion. Especially if you have a tumor that's not that common, or
Mm-hmm.
You should always see what else there is to offer. I mean, I found my surgeon through a friend that had the same cancer. Even though I was a professional, that's how I actually found my surgeon. You never know.
Yeah.
Well, we kind of went through that. Okay, so radiation is mostly a local therapy, so make sure they have 3D planning. So the 3D planning, most places have the 3D planning now, is aimed at the tumor, and it'll go in all different angles to protect as much normal tissue as possible. So they give it in small doses to treat normal cells, because the normal cells can repair themselves. They're always repairing themselves. And cancer cells are already messed up cells, as I said, so they can't repair themselves as well, and that's why they die. But that's why the radiation is given in so many different doses. There are some studies in breast cancer where they're giving like 5 treatments, but you can have long-term effects from that. It's often used post-resection to kill any remaining cells in area, or to treat whole area at risk, such as in post-lumpectomy. The side effects depend on the area that is being treated. If you're not treated to your head, you're not going to lose your hair from radiation. But anywhere you're treated, you're probably going to get tired after a while. It may be used for palliation of pain, like in bone mets. It's used if the tumor can't be excised. If the tumor can't be taken out, they might treat you as radiation for palliation. There is internal radiation, like the iodine seeds in prostate cancer. There's brachytherapy, such as the eye plaques. Brachytherapy can be used in uterine cancer and cervix cancer. Also, it's an option for prostate cancer. in high-dose radiation therapy. Radioactive drugs are targeted towards tumor and bone mets for prostate cancer. Yes?
I have a question. When I went through radiation, they gave me the option of 6 weeks, or I could do a higher dose for 3 weeks.
Right.
That was kind of basically what it was. And I said, no, I don't mind doing the slower process, that's absolutely fine. They said, oh, you won't burn if you do a higher dose. But I had people who took that route who did burn. I mean, I felt a little bit, like on a conveyor belt and factory base where you just push through as quickly as possible. I mean, what do you think? Is it better to do the longer dose? I mean, take longer?
Well, I'm more of a traditionalist, so I like the lower dose per fraction.
Okay.
Because then the normal cells can heal better. The studies show that as far as long-term survival, it's exactly the same. But it will damage the normal cells faster if you take the 3 weeks, because you're getting a higher dose per fraction. They probably got more sunburn, and you can get more scar tissue. And I like the lower dose. They even have a study where they give 5 treatments. They give a high dose. And in Canada, you're not from Canada, are you?
No, but
Okay. In Canada, they give a higher dose because they have less radiation facilities there. So they can't treat as many patients, so they give a higher dose. I mean, they have the same survival rate, but they'll have a higher risk factors, and you're getting more to the lung, because the lung's right under the breast, and they protect as much of the lung as possible, especially with the 3D planning, but you still get a little bit. So I like the 5 weeks. Did I answer your question?
you did, thank you.
And stereotactic radiation therapy is used in brain cancers. Now, there's proton beam radiation therapy, which is used in certain circumstances. It can be used in the eye melanoma too. It's a really intense machine. Moffitt does have one, and it gets a very high dose to a really specific place, and they have really good physics now. And didn't have one started, but they have really. It's really much better. And it is for recurrences or places like the brain, which that they can't go to the other areas. So it's used for really, really very specific things. And that's the proton beam, and sometimes they have to mask the head. Those are the seeds of the radiation. I mean, in the prostate. This is the high dose brachy therapy, and that's a regular linear accelerator. That's how the proton beam works. Okay, chemotherapy. The chairs in the chemotherapy place were much more comfortable. They luxury chairs, you sit back, and people just talk. It's like a party there. I did great during my chemotherapy. It took away my trigeminal neuralgia that I had which is like shingles that I've had it for 40 years, but took it away for 5 years. I asked them for more chemotherapy. I did. They wouldn't give it to me. I was going to go on a study, but they couldn't create a study for it. But neoadjuvant chemotherapy can be given prior to surgery to shrink tumors so that they can be removed. We talked about that. Adjuvant chemotherapy is given after surgery. It's given to treat any tumor cells that might remain in the body. So whereas radiation is given locally as a cleanup local job, the chemotherapy is given in case any cells escaped and it's going through the body. So like I was at high risk, one of my cells might have escaped and gone through my body because I had a T2 lesion already. That's why I was given the chemotherapy. But I didn't need radiation because I had the mastectomy. If I would have had a lumpectomy, I would have had the radiation locally. So chemotherapy is also given for main treatment of blood-borne or systemic type cancers for leukemias, as leukemias and lymphomas sometimes. Radiation can be given too, for example, lymphomas. Chemotherapy is used in metastatic disease because it goes all over the body. Many exciting advances are happening in chemotherapy where they can customize chemotherapy, decrease side effects, and markers. The markers are the main thing in chemotherapy. Now, given orally, intravenously, or targeted organs, and prepare yourself for treatment, prepare time, diet, support, Venice, and hair plan. I thought I was going to be Raquel Welch. because I have such bad hair. I thought I was going to finally have this thick, gorgeous hair. Oh, God, I looked horrible. We had it, I'm not going to much. I was 70 pounds heavier. We had to cut the whole thing. I look good in a baseball cap, though.
Isn't there a limit to the amount of radiation you can have in
Yes,
your
yeah,
lifespan?
every organ has a limit.
Yeah,
So, you can only give a certain amount, and that's part of what we have to learn. And you can't get re-radiated in an area. And that's why sometimes, like if you're radiated to the brain, then sometimes they'll use the proton beam to go in and get that one exact spot.
so that's just in an area because it's those organs.
Yeah, it's those
Okay.
organs. Yeah,
So if it comes up somewhere else, you could do
you could get
radiation
radiated in
again.
that area.
Interesting.
If your beams don't cross.
Yeah, they usually don't.
I wondered with Claire, since she had 33
Well, she's not gonna
radiation
get it
treatments,
anywhere
where
else.
could you go after that?
She's not going to need it anymore.
I know, but where?
Yeah, no, but
so
she
you
can get it
reached a
somewhere,
limit
yes.
of plateau.
Yeah, she could go somewhere else.
Yeah.
Do you want to mention the ice cap for
That,
Kim?
I had that in my plan and I forgot. Thank you. And I just spoke to somebody who had the ice cap and it protected their hair for the chemotherapy. But she really needed to put a lot of effort in because you have to put the ice cap on. It's much better than it used to be. But her husband had to be there and keep on replacing the ice and keeping it cold. And she had beautiful thick hair. And she wasn't young, so it wasn't like young, beautiful
What is
thick
the
hair.
ice cap?
It's for when you're getting chemotherapy and it protects your hair from falling out. Now, I can't say it always works, but it does work sometimes. And it definitely worked on her because she just finished her chemotherapy. She was at a lecture that I was at last night. And she had hair similar to yours. And it protected it. It was really neat. But her husband kept on replacing the
makes
ice.
the blood vessels constrict, so less chemotherapy goes into
Goes
it.
to the follicle.
To the follicle.
But it's really, 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 really cold, and you have to keep it really, really cold the entire time. I mean, you had to stand there and keep on replacing it and keeping it cold.
Wow, that's really
Yeah. So, the immunotherapy and vaccines. Immunotherapy trains your immune system to find and kill cancer cells better. It also helps produce more cancer-fighting cells. So their monoclonal antibodies are used to treat many cancers, but designed to treat and interact with specific targets. So your immune system normally has an off switch to stop from overreacting. So checkpoints inhibitors act to stop the off switch. So you have this off switch. It's kind of hard to explain. Your immune system wants to shut itself off so that it doesn't overreact, so you don't have like an anaphylactic reaction or something. So what they do is they turn off that off switch so that you can fight, so your T cells can fight the melanoma or fight the breast cancer. So Keytruda is that type of immune system fighter, a cancer fighter. So it lets your immune system fight the cancer. It sees the cancer as a foreign body and fights the cancer.
So when would you use immunotherapy versus chemo or radiation? What would make?
Well, Keytruda is used in like metastatic breast cancer, like a recurrence. It's not used right away.
Oh, okay.
Yeah.
Only if you've already had it. It's
Yeah,
coming
like
back.
if you're not responding to the chemo, or if you're at high risk or
Oh,
something.
okay.
Yeah.
So they wouldn't start you off on that.
They don't usually start you off.
Usually,
not?
usually doesn't kill the cancer. It just slows it down.
But it
Usually.
slows it down much longer than, I mean, people are living a very long time. They're getting a really high responses though. But anyway, so the T cell transfer therapy, this is very good. The T cell transfer, immune cells that grow naturally in tumors are taken out and grown in a lab. So there's the T cell. So they're taken out, they're grown in a lab, and they're turned into CAR T cells in the lab. So they're altered in the lab, okay? And then they're put back in. These CAR T cells are put back in once they're grown in the lab, and they grow millions of them. in the lab. Then they are infused back into the body so that they could kill the cancer cells. Okay? So that's T-cell transfer therapy. Immune cells that grow naturally in tumors are taken and grown in lab, altered to attack tumor cells with better, then through an IV, they're put back in. And I have melanoma, choriocarcinoma, cervical cancers. It's also done in lymphomas. Okay? And cancer vaccines, not to prevent, but to treat. Spirulacell is for I don't know much about that. For prostate and others for bladder cancer vaccines, melanoma vaccines, and more research is being done on the messenger RNA vaccines, which is like the vaccine for COVID. So it was messenger RNA vaccine. Okay, so this is the last slide. So after you're treated for cancer, it's not like it just goes away and you never had it. I mean, cancer goes away, but it does affect your life. Because either you have long-term side effects of the treatment, or psychologically, like it just, there's something in you that changes. I mean, it gets less and less as you're a longer term. I'm a long-term survivor, but at first, it's like you get a cold and you're sure that something's in your lung, or you get your back hurts and you're sure something's there. And as time goes on, it gets better and better. I mean, my problem was I was in medical school and just learning about all these other diseases. And they kept on saying, melanoma has no treatment. Melanoma. So it was a little worse for me. But eventually, you just learn your own body. And you learn your own aches and pains, and you learn that they're just normal. And the other thing that happens is, like when you're going through it, you build up this strength, or a lot of people build up this strength of, I've got to get through this. I have to get to my treatments. I'm going to go through my treatments. I'm going to go through my daily life. I'm getting that. I'm picking up the kids. I'm doing that. And you get through all that, and everybody is there to help you. And then 2 months later or 3 months later, you realize what you went through. But everyone else is like back to their normal thing. So give yourself a break if you need that. Find your support groups, find who's going to support you, and tell them. Sometimes it's not your closest family. Sometimes it is your closest family, but sometimes it's a support group in the hospital, or a support group at the American Cancer Society. Sometimes you have to step to somebody else, because sometimes they need to move on to what they're doing. Their normal life too, so sometimes you need some outside help, and that's okay, because sometimes they need a little bit of a break, and sometimes they don't. Sometimes they're right there for you, but every situation is different, so you have to find out what works best for you. I know in my case, a lot of people, everything was like so rushed because of the wedding and trying to finish the first year of medical school and everything. I just kind of went through the motions, and then 2 months later, I was like, oh, this is what happened. But everyone else was like moving on to their summer because they had a summer break. So I had to go somewhere else. And I'm Jewish, but I wound up at the priest's office at Georgetown, and he helped me. So you never know who's going to help you. So, but sometimes it takes time to get your energy back. So let yourself heal. When you're done radiation, which you might know, just because you're done doesn't mean the next day you're going to get your energy back. It takes a while. Is there any questions?
I have a question. There are so many cancer centers. Do they specialize in different types of cancers?
Usually there's a big group within the cancer centers, and then there's like medical oncologists that specialize in each one of the cancers. When I was working, because I was female, I saw most of the breast cancers, and uterine cancers and cervical cancers. So I mean, I crossed over and saw other cancers too, but so within each of the cancer centers, they'll have some specialists that gear towards one or the other.
Okay, so basically you have to research the cancer center as to which one you want to.
Sometimes they'll do that, yeah.
Okay. Because it's Moffitt here, and then in Tampa now, Sarasota is opening up another new brand.
Sarasota is gonna be opening a breast cancer center really soon.
Okay.
I just heard that yesterday. that
Okay.
the
Yeah, they just
Sarasota
finished
Memorial Hospital
building.
is dedicated in
Right.
the area.
There is a certain certification that only few handfuls of cancer centers have as a nationally, and I forgot what the code is, it's an acronym, for excellence in cancer care. And there are only like 30 in the country.
Oh,
As a site for multiple cancers. Moffitt is like number 8 or 12 in the country.
Okay.
Along with places like
Hopkins.
Hopkins and Sloan Kettering Memorial and the one in Houston, MD Anderson. So,
okay.
Yeah,
So-
but that's not, yeah. That's true.
So yeah, you have a cancer center at Sarasota, but that's not the same thing as being a NIH approved
Facility.
facility.
Okay.
Right, but
Okay.
what you want, see, like if you were diagnosed with breast cancer,
Uh-huh.
what you want to, you need to look, like, first you want to look on the sites and, like, first of all, you need to know what stage you are and know all the different options there are for treatment. And decide, like, do I want an excisional biopsy and radiation, or do I want a mastectomy? You know, if you are at a low stage and you have the choice. And then you need to look at all the different kinds of surgeries that there are. Like, I knew I wanted an alloderm covering with a mastectomy, so I didn't have to go through the extensions or anything, and I'd wake up with the breasts already done. So there aren't that many places that offer that.
I have a friend that went through that.
And I had to go up to Terrytown. Now, that's not one of the big institutes, but I went to the guy that developed that surgery,
Okay. Okay.
who's well known for that. So you don't always need a,
A big no.
yeah. I mean, he is extraordinarily well known, but he was up in a different area.
I think that's also probably an important point too. Not everyone needs MD Anderson or
Right.
or
Yeah, and then the
Moffitt.
chemotherapy I was getting, I could get right here at Florida Cancer Institute, because it was the same chemotherapy I would have gotten at MD Anderson, or it
Okay.
was the same exact chemotherapy. And they called Moffitt and reaffirmed that I was going to get the same chemotherapy. I already knew I was going to get chemotherapy, but he did it for show because he knew me.
Right.
But it was the same exact chemotherapy, because it wasn't a high stage, it was a regular stage. I was getting common chemotherapy, so I didn't have to go track up to Tampa to get it. I could get it right here. So it depends on how high your stage is and how unusual your tumor is and everything. And some people don't mind going through the extenders and everything. I just, it's not that I was going to survive better.
Right.
I wasn't.
Do you have an option of where you want to go, or do you have to get a referral from your doctor?
It really depends on what insurance that you have, but like those doctors, they took Medicare. I didn't have Medicare at the time. I had private insurance because I was 48, but you do have it.
So you can just call up a place and just say, I want to be seen, or I need this?
Lots
Or
of times you
have to have a
can.
doctor's referral?
Yeah.
You just call?
some places not. Some places want a diagnosis of cancer before
Well,
you're seen for.
you're not going to go there
Well,
unless you have a
yeah,
diagnosis.
so you do, but I'm saying, like, if I wanted to choose, go to Mayo Clinic, would I have to have my doctor here send me a
Sometimes you can get in
referral?
faster. It depends on how fast you want to get in,
Okay.
which is usually pretty fast. But you have to understand too, the cancers don't grow like to the next day and the next day. But you don't want to have to wait 3 months.
Often the surgeon or the pathologist will send the slides out of the biopsy to a super center to look at them, to say this is just a typical thing or it's something else that might be treated differently. But as far as I'm concerned, for second opinions, there's no harm in going to getting a second opinion at a top center. But the surgery, for example, a lot of thyroid surgery, and so it's fine to do with a good surgeon in the community, but you might want to get a second opinion from an expert about, as Dr. Adler said, all the possibility, all the options, other types of surgery, other type of treatment. And if you're happy with the treatment, that your surgeon or team is offering you and going with
But
that.
like with the ependymoma, the type of surgery that I wanted wasn't done by many surgeons. So you want somebody that's doing the surgery. And with the enucleation, the people at Georgetown weren't doing the low touch. You need to know how many times that doctor's doing that surgery.
I read that.
There's also something called a tumor board.
Mm-hmm.
Hospitals have a tumor board, which
Yeah.
is a group of,
Yeah, if you have an unusual tumor, like my meningioma was unusual because I had
Okay.
4 tumors. So we wanted it presented at tumor board. And what they do at tumor board is they bring all the specialists together. And that's how I was trained. I was trained with tumor boards. And the surgeon, the medical oncologist, the radiation oncologist, and the residents, it's usually at the university hospitals that have it. They all come together and they'll discuss your case and it will be presented. They usually only do that for unusual cases.
Okay,
But-
okay.
But if you have an unusual case, they'll present it at a tumor board. I mean, I've had my tumors presented at tumor boards. And then they discuss how they want to treat it. Where I was trained, they did most cases at tumor, they met every week, twice a week, and they presented all the new cases, most of the new cases at tumor boards, which is one of the good things for being at a university center.
So you were trained at Georgetown?
I went to school at Georgetown. I was trained at George Washington,
Okay, okay.
which is also in DC.
Right.
I think that's it.
thank you.
Sorry for that.